Hello, everybody. We are here for session 2 of the OB-GYN meets the medical oncologist. And we are talking everything on the intersection between menopause, women's health, and cancer. And so for session 2, we've got a nice update on Dr. Teplinsky's time at the American Society for Clinical Oncology annual meeting.
Yeah, so ASCO, biggest oncology meeting globally. It happens once a year. Big things happen at that meeting. Now, things happen throughout the year as well, but there were some really important topics regarding breast cancer that I want to make sure we touch on today. So we have three big topics we want to talk about. Obviously, this wasn't everything that was discussed, but highlights. So we're going to talk about GLP-1s. We're going to talk about SERDs, selective estrogen receptor degraders, and then some fertility and breast cancer updates.
Amazing. These are all topics that both of our audiences really care about. And if you're listening to this, please subscribe to both of our Substacks so that you can get the full archive of future recordings that we're going to be doing. We're hoping to do this 1 to 2 times a month, bringing interesting updates and insights from both of our perspectives. So let's get into it. GLP-1s and breast cancer, huge topic. So let's cut through the noise. Tell us what you learned at the conference.
Yeah, so there was a lot of different studies, a lot of focus on GLP-1 medications, both in potentially reducing breast cancer risk in somebody who's never been diagnosed, as well as reducing the risk of disease progression to metastatic disease. Now, it's not just in breast cancer. Obviously, this is breast cancer focused, but there are a number of other cancers where we might see this. And I think where I am at with all this is that we certainly have a signal. We have enough studies now to show there's some sort of signal in reducing cancer risk, reducing the risk of recurrence. And we've not just at this meeting, we've kind of seen it throughout. And thing to remember with these studies is that they are looking back. They are going back to these large databases and pulling diagnoses codes. So they're saying who has ever been prescribed a GLP once or twice. And then they look to see what was their incidence of breast cancer, if they had prior breast cancer, was there then a diagnosis later of metastatic disease. So when you have these large databases and you're querying them like that, you're not getting that nitty-gritty of what type and when and all that stuff that we really want to know.
So, what are the practice changing or practice shifting things that you learned from these GLP-1 studies?
So, we have this signal, and everyone wants to know, well, should I go on a GLP-1
Hmm?
to lower my risk of breast cancer, lower my risk of recurrence? And I get it. I mean, I think that's a really important and valuable question. For right now, we have to remember three things. Number one, these are retrospective studies. So they're looking back again, all those caveats that we talked about. Number two, these are in patients that were prescribed a GLP-1 for what currently meets the indication, which is generally based on obesity or diabetes, overweight with a certain weight related condition. And again, that's nuance. And these are generally older GLP-1 medications and not some of the more newer ones that we use. So we don't know at this time is will the same benefit apply to somebody who does not meet the current indications for GLP-1. And so we're certainly not yet at the point where we're strictly putting people on a GLP-1 for the cancer risk reduction perspective because we don't know exactly how they reduce cancer risk. Is it through weight loss? Is it through impact on metabolic health and insulin resistance? Or is there actually something specific to the drug itself? There's a lot of ongoing research about maybe cancer cells have GLP receptors and what is that doing? So we need more. And I personally think we need to move on from the studies where we're looking back
Yes.
and we need prospective data. We need to put people on GLP-1 medications and see what
Follow them.
happens. I mean, because we look, there's a signal I think we can all agree, but how are we now moving into action?
So, I think that's super important. And I think what you said about the studies were done on women who were either living with obesity, overweight, and met criteria for the
Mm,
indications for
Yep.
GLP-1s. And so, what do we know, kind of taking a quick step back, what are the big picture things that we know about obesity and breast cancer recurrence? Let's put aside those at risk for getting breast cancer, because I think there's such an interest in women who are really managing recurrence risk reduction. So, if you have a patient who is overweight or living with obesity, what does weight loss do for their recurrence risk reduction? What do we know? Just putting aside the GLPs just for a
Yeah,
minute.
we have known for a really long time that weight loss reduces the risk of recurrence. Now, I think that's a more complicated discussion because we certainly know BMI is not everything, and I like to
Yes.
focus on how are we accomplishing that, right? How are we moving? What are we eating, right? How are we sleeping? All of those things, and I think they're so intricately tied to impact on metabolic health and insulin resistance. So again, is it the GLP-1 or is it the impact of the GLP-1, and could we accomplish the same risk reduction by a really focused effort on diet and exercise? Now, I will say, and I think we all agree with this, is that when you are premenopausal and you're on ovarian suppression, you're on endocrine therapy, it is really hard to do the lifestyle things for a lot of people. It sometimes feels like you're climbing up a mountain and there's a big boulder rolling down
Yes.
at you. And so I think that for some people, the GLP-1s are remarkably effective, but we're just not yet at a point where we can say we should be prescribing GLP-1s for the sole benefit of risk reduction.
And frankly, I don't think there's a lot of patients out there who, well, maybe there are who want it for the sole benefit, because I think just what you said, there are so many breast cancer survivors in the middle of treatment, long-term survivors who put on that weight, and their body composition, again, more than the BMI, there's
Yep.
more visceral adiposity. There's some insulin resistance, these things that you were talking about. And, so if you're benefiting from that for your overall
Yep.
health, we think you're hopefully benefiting. So I think the take home that I'm getting from this is that if I have a breast cancer patient survivor at any stage and she is dealing with obesity or significantly overweight, that a GLP-1 is something that we can feel good about likely
Yes.
using. And they shouldn't be dissuaded saying that it's not
No.
safe.
Exactly.
So I
Exactly.
think that's important. And then the other takeaway I'm getting from this is that if I have someone who is of a normal or a ideal body weight and things, they've got good, muscle content and their
Mhm.
metabolic health is overall pretty good. We shouldn't just be throwing them on GLP-1s at this point for a lowering of risk reduction, unless they have some other criteria here.
E Exactly, and we don't have data on microdosing, so taking a
Yes.
smaller amount, and also we wanna be mindful of where we're getting or sourcing these medications if people don't meet the criteria and want to try them, right? I'm always
Yes.
careful about where are you getting those prescribed because there are a lot of on-off,
Yes.
questionable ways to
Very
get
much so.
medications right now, so just be mindful of that.
And then the one last question I have from a little bit of concern about the GLP-1s in the breast cancer patient who is already at risk for, muscle loss, osteoporosis risk, that if you're going to use a GLP-1 and you are particularly premenopausal on ovarian function suppression, that we really have to be very careful about maintaining high quality nutrition and strength training, because if you're reducing calorie intake, you might be reducing overall really good nutrients for your bones, for your muscle, for your brain, etc. So this is why I think if a breast cancer patient is going to use a GLP-1, it needs to be supervised by somebody who knows what they're doing and where the source is good, because I'm a little concerned about the blending of GLP-1s versus totally unregulated peptides for inflammation and all these other things, which may not be safe. We don't even know what is in some of those other unregulated peptides. So just like a word of caution, which I know you agree with me on that for sure, right?
100%, and I will
Yeah.
tell you the people who have the best outcomes are, people who are marrying the 2 of the diet and the strength training with the GLP-1s, and we're actually
Yes.
looking at this and impact on bone density, and we've seen really good results in the people that are doing the 2 together.
Together, yes. It doesn't mean you're going to lose muscle or bone if you go on these, but it means you need to do it correctly and using all of
Mhm.
the tools.
Yep.
Okay. One last question. Are there any ongoing prospective trials that are planned or happening or enrolling patients yet?
Yes. So there are two that I'm aware of. I think more are coming. They're called Trim Wise and no, Trim EBC and Fit Wise. If you go to clinicaltrials.gov, you type in GLP-1 and breast cancer, you can see what else is out there. And those are accruing patients prospectively, and they're doing really cool things. They both of them, I believe, have a lower cutoff for what is currently meets criteria. So that's actually nice because we'll have more data. And they're looking at circulating tumor DNA and risk of recurrence and other things. So I think we're going to see data hopefully very soon about how to use these in our patients. And I do think in a few years that they may be part of our toolkit a little bit more broadly than they are now, but we certainly need that research first. And again, we want to make sure we're using them responsibly in combination with lifestyle habits.
Yes. And I'm also assuming it's very important for you to tell your medical oncologist, especially if you're taking oral medications at all for your cancer therapy, that we don't know about, right? Absorption, gastric, delay, or like, is it affecting the absorption of some of the oral cancer medications if you're on a GLP-1? Again, so really make sure that you're including your medical oncologist and you're working with someone who is a board certified specialist in managing these meds. Awesome. Let's move on. What's the next big point you want to tell us about?
So big point is SERDs. So these are selective estrogen receptor degraders. Everyone is very excited about this, and with good reason. So
Yes.
what are SERDs? Very briefly. So we have our tamoxifen, we have our aromatase inhibitors, and aromatase inhibitors block estrogen production. So there's less estrogen or no estrogen to bind to any cells that are circulating and have an estrogen receptor. What SERDs do is they actually don't go after that circulating estrogen, but they go after and block and degrade the estrogen receptor. And there's a number of different SERDs already. Faslodex is a SERD that has been around for metastatic breast cancer for a long time, but it's an injection and it's not very effective. So now we have on its own, it's effective in combination with other medications. But now we have a number of oral SERDs. We've have several approved in metastatic breast cancer, and more are coming. There's a lot of nuance and research being presented about how to optimally use them. But the big news is that we're hopefully going to see an approval for the first oral SERD in early stage breast cancer by the end of November of 2026. That drug is giredestrant. This is on the basis of the lidERA trial, and I'll briefly talk about that. So they took patients with stage 1 through stage 3 breast cancer, and half of the patients got their tamoxifen or an aromatase inhibitor. And if they were premenopausal, they also received ovarian suppression. And then half the patients received giredestrant with ovarian suppression. And what they found was that the use of giredestrant reduced the risk of recurrence by 30% compared to your standard of care endocrine therapy. Also was better tolerated. There were less discontinuations for things like joint pain, which is super exciting. And so that's where we are right now. What they presented at ASCO this year was that there was no difference whether you were using giredestrant in premenopausal or postmenopausal. So that's
But they had to have ovarian function suppression.
exactly. So
Because so the reason why I bring this up,
yeah.
Eleonora, is because on social media, in comments, people are like, "Oh, I'm so excited. It's like a new
Yeah.
tamoxifen. It's not going to make me menopause." I'm like, no, no, no. Right now, you must be. The data is that you have to have either naturally menopausal, ovaries removed, or on ovarian function suppression. That's true, correct?
Yes. And so there was one study presented a couple of weeks ago at the European Oncology meeting, which they actually looked, it was like a 4-week window before surgery. And they looked at giredestrant alone, and it was effective, but nowhere near as effective as it was with ovarian suppression. So I suspect the approval, although I don't know, but I do think the approval will be in combination with ovarian suppression. It's not that you can't use it, but that
So
doesn't have
that's my
this.
question. Is it something that just if, say, someone wasn't tolerating, and I know this isn't what the initial approval is going to be,
Yeah.
but just thinking big picture, um, might it be, you think, in the future part of this kind of escalation pathway of like higher risk patients get this, lower risk patients get this? And that do you think that there's any way that it will ever be used in a premenopausal woman who's maybe a lower risk of recurrence without ovarian function suppression? Is there anything to suggest that it doesn't work in that setting?
No, we know that it will work. We just don't know how effective it will be.
Yeah.
But I do think, so we'll get the approval hopefully by the end of November, right? And there's a big question about how much it's going to cost, and that's a different conversation. But then we'll get a lot of studies that will come out, a lot of real world data about what is happening in the real world as people
Mhm.
start to use the medications. And hopefully we will have some studies on giredestrant alone. I
Sure.
think those studies are going to be challenging. If we already know that it might be less effective, it's probably not ethical to do a study, right, where we're going to give someone a less effective medication.
Right.
But I think realistically, we'll start to see people who are having, trouble with ovarian suppression, and we'll maybe take a break and we'll see what happens. So I think as we get the approval and then we start using it, we'll get a lot more answers to questions. I mean, we've not, it's only been used in one, in this clinical trial. So I don't have any experience. We didn't have the trial open, so I don't have any experience with the drug.
Yeah.
And so I think time will tell. I mean, the other part that's interesting is that the discontinuation rates on the study were much lower than what we see with endocrine therapy in the real world
Mhm.
in general. And so is it a function of being on the trial? And so I think more will emerge.
But there was some
Um,
data about it having people having less severe joint pain than women who
yes.
were on aromatase inhibitors. So slightly
Yeah.
better outcomes or better outcomes in terms
Yes.
of cancer recurrence, but also it seems a slightly better side effect profile. Is that correct?
Exactly.
Yes.
Exactly. And so
So that's
the
like a big
question.
news there with the side
Yeah, I think
effects.
it's huge. I mean, will everyone be on giredestrant? I don't know.
Mhm.
And I will say there are other SERD trials. Giredestrant's not the only kid on
Not
the
the only
block.
one.
It's
Mhm.
just the first trial that's reported out. So I think in the next few years that this is a field that's going to, really change. And the other thing to keep in mind is that this study was not in combination with a CDK4/6 inhibitor like
Mm.
Verzenio or Kisqali. There's a sub-study that's ongoing. We don't have that data yet. But what they showed at ASCO was that giredestrant with a CDK4/6 inhibitor in first-line treatment of metastatic breast cancer was not actually any better than an AI with the CDK4/6 inhibitor. So there's a lot of questions about
Still to
what
learn.
optimal use. So more to come, but I will say very exciting. Also very exciting because we have a date from the FDA by which they're going to make a decision. So it's like things are
Yeah.
moving.
Yeah, that's very
Mhm.
exciting. All right, so stay tuned. We'll come back in the fall
Yeah.
when we get that decision, and we'll learn more. So before we wrap this up, we want to get to one more point on updates on pregnancy after estrogen receptor positive breast cancer.
Yeah. This was big. I will be very, very quick here. And this was actually published, this update was not presented at ASCO, though there were some other smaller
Oh,
studies.
mhm.
But this is a big update from the positive study. So the positive study is this big study that looked at, can you temporarily stop endocrine therapy after being on it for 18 to 30 months in patients with hormone receptor positive breast cancer to attempt pregnancy? And when the positive study was presented, it showed there was no short term increase in the risk of recurrence. And short term because we hadn't followed the patients for long enough. And so now what they published in the Annals of Oncology was the 71 months, so nearly 6-year update of following these women, and showed that again, that interruption and then resuming endocrine therapy, most people did resume, um, did not increase the risk of recurrence with this average 6-year follow-up, which is really important because we think about that high estrogen level that happens in pregnancy. So I think huge couple of caveats. One, most of the patients were stage 1 to stage 2 breast cancer. There was a study at ASCO, it was just an abstract, but they showed that for that higher risk group, maybe waiting 3 years
Yeah.
before interrupting endocrine therapy is important. And that's what we do in practice anyway
Yes.
for our higher
Mhm.
risk women. And it was done without CDK4/6 inhibitors. So we don't know if you're on 3 years of Kisqali, how that fits in. So it's still nuanced and individualized, but really further supports the safety that we can do this for at least some, maybe hopefully most of our patients. And I hope that women, my takeaway on this is so important to make sure we talk about fertility preservation before starting any form of cancer directed
Yes.
therapy, right? This is often thought about doing it before chemo. We should be doing it before tamoxifen, before aromatase inhibitors, before ovarian suppression.
Yes.
And then making sure that if your doctor is saying to you, absolutely not, you can't do this, ask why, push back
Yeah.
a little bit and say, look, we have this update. How do I fit in? How do I fall into this group of women, and does this apply to me?
Amazing. And so with that, I think we just came up with some topics for the future where we can dive more in about pregnancy and more in about
Yeah.
this idea of interrupting therapy. Like, what lessons do we have from people taking a
Yeah.
2-year pause for pregnancy versus some of my patients when we get into the menopause symptoms who have maybe dealt with a lot of side effects and they've had a hard time and maybe they need just like a short pause. Can we allow it for that reason if we are allowing it for having a
I
baby?
know.
And I
I
think the
mean, I
answer
think
is
we have
yes there, but I think
yes.
that deserves a kind of intelligent kind of talk, topic on its own. So always
Yes.
so
And
much
we
to
have
talk about.
data, and we have data for longer pauses, so maybe we'll do that for our next,
Yeah, that I think that would be really interesting.
yeah.
So this was great. So make sure you follow both of us on Substack, subscribe, and you can add some comments on what you would like to see in the future. And if you have any questions from today's episode that we can answer, we'll try to answer those on social media and as well as in the comments on Substack. So have an
Thanks
amazing
for
day and
being here.
thank you for meeting me.
Bye, guys.
Bye.